presentation that will be given by Professor Carlos Morillo, the BENznidazole evaluation for interrupting trypanosomiasis trial. Carlos.
Thank you, Jose Ramon. So some of you might be asking what the trypanosomiasis thing is about, and this is the agent that actually leads to Chagas disease, and this study was funded by several agencies and not by industry. Just a brief refresher how the disease is transmitted. There are different bugs that are blood-sucking bugs that vary actually among different countries. And once they bite you, they defecate on your skin, and then you scratch your skin, and that's the way you insert the parasite into your bloodstream. Once the parasite is in the bloodstream, there's two things that can happen. One, you can have an acute infection, which most of the time doesn't have any symptoms, maybe a flu-like thing. Only 5% of the time, some may present with acute cardiomyopathy. But then it stays dormant for many years, 20 to 30 years, and we do not understand exactly why 20 to 30% are going to develop some alterations either in their GI system or in the heart with a cardiomyopathy that has severe problems. Now, the parasite seems to be very important in developing the disease, but also some autoimmune mechanisms. So we don't know if treating the parasite actually will reduce outcomes in patients that already have early cardiomyopathy. Now, this disease is not only something that is important for people in Latin America, as you know, and Europe is going through some migration patterns right now. This is the third most common parasitic disease globally, and it's the most common form of non-ischemic cardiomyopathy in Latin America. There's about 5 to 7 million people infected, so up to 2 million people will end up having cardiomyopathy within 20 to 30 years. And you can see that in Europe and Spain, there's over 100,000 people that are infected with T. cruzi. In the States, over 300,000, et cetera. Now, we embarked in doing this study in which we were looking at patients that had chronic Chagas cardiomyopathy between 18 and 75 years. They had to have 2 of these serology tests that are positive for the reaction to T. cruzi, which is the agent that produces the disease, the parasite. And they also had typical electrocardiographic changes, such as right bundle branch block, left vesicular block, which are typical of Chagas disease. Patients were randomized to receive the antiparasitic drug, that is BENznidazole, at a maximum dose of 300 milligrams a day, or match placebo for anywhere between 40 to 80 days, and this is depending on weight. We follow up the patients at 11, 21 days, end of treatment, 6 months, and every year until the end of study for a mean follow-up of 5.4 years. Now, the primary outcome was the time to first event of a composite of death, resuscitated cardiac arrest, sustained VT, need for a new pacemaker or an ICD, cardiac transplant, new or hospitalized heart failure, stroke, TIA, and any of the systemic embolisms. Now, basically what happened is that we did not see any difference in the primary outcome. So overall, treating the parasite did not have an impact on reducing this, although we did see that around 2 years there was some separation in the curves, but after 7 years, nothing really happened. And again, we studied almost 3,000 patients, 854 patients that were randomized, 1,400 and short to each of the treatments. So the main conclusion was that treatment given in the way we gave it for 40 to 80 days in patients that already have established Chagas cardiomyopathy did not significantly reduce the clinical progression despite reducing the PCR parasite detection. So we did show activity against the parasite, but it did not seem to diminish with time during follow-up, and it did not have an overall impact on our main clinical outcomes. Now, we did also show that BENznidazole was well tolerated, and the permanent discontinuation rates were lower than has been previously reported. So that's the main trial. And I think I'm within the 3 minutes, Salim.
Yes, less than 3 minutes.
Oh, it's a good standard deviation.
Crystal Fenn with MedPage Today over here. There you go. So what is the thought in terms of treating earlier? You've showed the results for treating established patients already, but if you were to treat soon, would it have any different impact?
Yeah, that's an excellent question. We don't know, and I guess that would be the next big trial to see if we treat these patients earlier. So in other words, that's what is known as the indeterminate stage of Chagas infection, in which patients have the serology, but they still have not developed the cardiomyopathy. So indeed, if we treat these people earlier, and some of the studies that have looked at patients in this stage seem to respond even better, at least from the PCR perspective, to BENznidazole. So that is potentially the next step here. Or the other question as well, maybe we didn't give enough treatment. Maybe this is like other diseases like leprosy or TB, in which you have to do pulses of treatment throughout time until you really get rid of the parasite.
Yeah, Steve Stiles, the Heart.org Medscape Cardiology. Are there other reasons to perhaps giving the agent to the patients, non-cardiac reasons for eliminating the organism? And have you, is there anyone looking at treatments for autoimmune disease in this?
Yeah, those are both good questions. There's been some trials done in the past, very small, trying to modulate autoimmune disease, and there's some trials that are actually in the works trying to look at modulating metalloproteinases and other of the proteins that actually lead to cardiomyopathy, but there's still nothing really ongoing. Was this related with other causes of mortality that would have not had an impact really on the clinical outcomes? I don't believe so, but we did have a significant amount of the overall rates after 5 years were about 28% of the primary outcome, of which the main outcome was death. So it's about a 3 to 4% rate of death on an annual basis.
Question?
Any further questions?
Ed Sussman, MedPage Today. Is there any way to screen for this disease in endemic areas? How expensive is the test?
Yeah, well, the disease is screened by doing a blood test. It's a serology. The serology, basically what it tells you is that you've been exposed to the parasite that creates this autoimmune response. So there are 3 different tests, ELISA, and different tests that you do anywhere in the world, as a matter of fact. As a matter of fact, the main way of transmission before this was blood transfusions. And today in most countries in the world, if you come from a region, of an endemic region, for example, myself, I'm from Colombia, or if you come from Bolivia, for example, in Bolivia, the seroprevalence is around 20% among the population. So if you're in Spain and you're going to go and donate blood and you come from one of these countries, you're going to get a serology for Chagas, and depending on what they find, they will offer or not treatment.
More questions?
Any more questions?
Yeah.
Yes, please.
How typical is it for patients who are infected with the parasite to progress to cardiomyopathy?
Yeah, again, only 20 to 30% of the patients will progress to cardiomyopathy, and we still don't understand which are the patients that are going to end up having those developing heart failure and cardiomyopathy. And it takes 20 to 30 years. That's the other challenge, because if you do a trial in the indeterminate stage, like they were asking, well, treat earlier, fair enough, but it's going to take 20 to 30 years and only 20 to 30% to develop cardiomyopathy.
I think it's worth noting that this parasite causes one of the largest causes of cardiomyopathy in the world. And this is there have been small trials, but this is the first really large trial with long-term follow-up. The other thing is the parasite goes inside the cell and remains dormant. So it may well be we may need repeated treatment or new treatments or combination therapy. We don't know. And unlike most things we do in the West, where there are dose-finding studies and all of that, in this case, the regimen is an empirical regimen tested in acute phase and in indeterminate phase. My colleague here was saying that the ESC had a session on tropical cardiology the first time, and these diseases are becoming more global as people travel, and so I think this is an important step.
Yeah, because in such symposium that was organized by ESC, by the Spanish Society of Cardiology and the Inter-American Society of Cardiology, was emphasized the importance that these diseases are here in Europe. Chikungunya is a big problem in many European countries. Dengue was a big problem in Portugal these years and in other places in Europe. So this is very important to emphasize that tropical cardiology is not only in the tropical countries, but also is a health problem nowadays here in Europe, yeah.